Thank you so much for the kind introduction and for the opportunity and honour to give Ads Talk 2021. As we explore whether there are equal outcomes for all disabled children, I hope you will hear the sentiments that Adam would have wanted to express were he able to now, and those of his family throughout my presentation. I give this talk in Adam's honour and with thanks to his family for their ongoing support and awareness raising about the challenges faced by disabled children and some of the solutions that can be helpful. I'd like to start by explaining what I mean by the term disability. I use the WHO, World Health Organization's conceptual framework of disability, or the ICF, based on the International Classification of Functioning Disability and Health. What this means is that disability isn't black or white, but depends rather on the interaction between a whole range of factors. Of course, there's the health condition affecting the child and how this influences body structure and body function. But also, very importantly, this framework acknowledges the activities that the child or young person wants to engage in and their participation, which means not just being present but actively interacting with the activity. We know there can be personal factors that make some children and young people more resilient and others more vulnerable. And then the environmental factors are all important. And these aren't just about how wide the doors are or whether there's a ramp or not, but include policies and practices in systems, organisations and structures, and the attitudes of other people in our society and communities. I'd like you to indulge me by turning the clock back to when I was a medical student at Manchester University in the early 1980s. I learnt a huge amount during my paediatric attachment by being sent all over the northwest of England to listen to the stories of families whose children and young people had a condition called the Poland anomaly. The Poland anomaly is where there are missing parts of the muscles of the front of the chest wall with variations in reduction in function and structure of the upper limb and hand on the same side. So it's a condition that has a spectrum of physical manifestations. What the professor wanted me to think about was what might have been the causal pathway for this particular condition. But I was also interested on hearing about the family's journeys and experiences. So all the families recounted to me how important it was about how the news was shared with them and how those memories stayed with them throughout their journey. I noted that the outcomes of the children and young people varied significantly, and that this wasn't proportionate to the degree of physical impairment that the child or young person experienced. However, there did seem to be a significant relationship between how the news had been shared and how families were then able to embrace their child's difference or not. How families embraced that difference was linked to their outcomes in confidence and ability to participate and engage in the activities that they wanted to do. If the difference was portrayed as bad news, that was using a deficit model and thinking about all the things the child or young person wouldn't be able to do or wouldn't be included in. And I want to move away from this sort of a start to disabled children and their families' journeys and rather frame things as difference. This means that the journey is going to be different. But it doesn't mean it's all bad. it can still be confident, it can still have positive outcomes. And indeed, where the news had been framed at the outset for families as difference, and families were encouraged to problem solve and seek out the adjustments that were required, those young people blossomed and were able to participate in the activities they wanted to do. Whilst when bad news had been shared, families wanted to hide away their child's difference. I remember one young man telling me how he was frightened to take his top off on the side of the swimming pool with the other children because he didn't like them to stare at him, and he felt very low in self-esteem. The lesson I learnt from this is that we professionals can have a profound impact on the journeys that families follow, depending on the way we frame things at the very outset. So I would encourage all not to think of disability and difference as bad news, but rather to think about difference, a different journey, and what can be done to improve and support outcomes. So I've now been a practicing paediatrician in the field of paediatric disability for more than 30 years altogether. So I've got quite a lot of experience to think back on now. And I've been witness to significant variation in healthcare and outcomes for disabled children and young people. I've witnessed diagnostic overshadowing, where folks stop when they see the disability and blame everything on that. Why is she short? It's because she's disabled. Why is he behaving in that distressed sounding way? It's because he's disabled. So instead of following the usual care pathways or even doing the basics such as weighing and measuring or looking at eyesight and hearing, things are just put down to the disability and the story stops there. I've witnessed passive monitoring of the natural history of disabling conditions, instead of proactively thinking ahead about what steps and adjustment might be taken to improve quality of life or treat reversible causes. I've seen disabled children denied interventions or access to intensive care because of the fact that they are disabled. The other words for these experiences and reflections would be inequality, nihilism. Oh, it is like it is, and that's what we have to accept. Discrimination. I believe we need to move on, acknowledge and call out when we are witness to these aspects of care for disabled children and young people if we are genuinely to improve outcomes for everybody. It's just not my say-so that things are unequal. Back in 2006, MenCap produced this report, Death by Indifference, really salutary reading describing the 6 lives and deaths of people with a learning disability who died from common things like constipation, chest infection, sepsis, where people hadn't followed that systematic approach to identify treatable causes but had been blinded by only seeing the disability. This was further borne out in 2013 by the confidential inquiry into the premature deaths of people with a learning disability. This highlighted that women and men with a learning disability are likely to die 29 and 23 years sooner than those without a learning disability. I'm sure we all remember the Winterbourne View scandal back in 2012, which evidenced the abuse, shocking abuse, of people with a learning disability in residential facilities. Lots of reports were produced and lots of initiatives, but sadly, Panorama again needed to shine a light on the abuse at Wharton Hall. Again, the abuse of people with a learning disability, those environmental factors, people's attitudes, discrimination. Scroll forward to COVID. We know that people with a learning disability experience death at 6 times higher a rate, at the very least, than people without a learning disability. I say that at the least because I don't think we're yet good enough at flagging and identifying everybody who in fact has a learning disability. And then there come those do not attempt resuscitation orders that were put in a blanket way over the lives of people with a learning disability without seeking their views or those of their families. Discrimination, inequality. This talk isn't meant to be all doom and gloom, but we do need to call out a name when discrimination is present. I believe there are positive keys and building blocks to achieve better and more equal outcomes. We need positive, inclusive attitudes, policies and practices underpinning and pervading all of our society and communities that honour the equal rights of everyone. I believe that universal services are required to be inclusive, with proactive adjustments in place when they are needed. I believe that specialist services should be accessible regardless of geography or starting point or who the managing clinician is. All of the above will only work, and we will only be able to evidence better outcomes if there is robust, comprehensive population data about the needs of all children. Only then could we describe in evidence whether a positive difference has been made or not. So let's look at some of these aspects in a little bit more detail. Improving societal attitudes and inclusiveness of universal services. One of the outcomes of the Winterbourne View review was that the Department of Health decided to fund an initiative involving e-learning that would tackle societal attitudes and target those who may work or volunteer with disabled children and young people throughout all aspects of society. And so Disability Matters came into being. This was underpinned by a collaborative consortium led by the Royal College of Paediatrics and Child Health, and I commend the resources to you. The reason I think Disability Matters worked is because it was completely co-produced with disabled young people, parent carers and other experts at every step along the way. Thank you, Adam. Thank you, Zoe, for your participation and partnership and co-production in these resources. The resources are free for everybody to access, and there is truly something for everybody to learn from. So the breadth of topics, which was informed by the views of young people themselves and their families, include those on understanding what disability is and is not, including hidden disabilities that aren't immediately obvious. There are sessions on how to work with disabled children and young people. A significant number of sessions on different aspects of communication, so vital. Communication with the child, with the family, between professionals, across agencies. Working in partnership and together to achieve better outcomes. Then we reflect again on those environmental factors, family and society, the world around me. The importance of parent carers and support for them, finance, transport, environmental factors. There are a number of sessions on decision making and growing up, including the Mental Capacity Act and best interest decision making, and transitioning to the adult world and to adult services. Understanding behaviour and emotions is so important if we're not to misunderstand and misinterpret, and there are a range of learning sessions across that domain. There are then a number of sessions on health and well-being, and all of the sessions include little nuggets and gems of information and positive tips for environmental adjustment that really can improve the experience and therefore outcomes for disabled children and young people. How then do we improve equality of access to specialist services? Part of this, I believe, is we need to reduce variations by improving training for paediatricians and the wider team in all aspects of paediatric disability. I was fortunate to be able to help lead on developing a competency-based training programme in paediatric neurodisability and to get a separate subspecialty up and running, which has now been in place with training programmes across the United Kingdom since 2005. I've also been privileged to be involved in the Sheffield Paediatric Disability Distance Learning courses. These complement paediatric clinical training and also enhance the knowledge and skills of anybody working with disabled children who wants to learn more. Improving the knowledge and skills of the specialist workforce will hopefully improve outcomes in a more equitable way. I've already talked about the importance of recognising learning disability and giving it its name. So again, we need to focus on definitions. When I talk about learning disability, which is the term that families tell us they prefer us to use, I use this as synonymous with disorders of intellectual development as described by the International Classification of Diseases, ICD-11. Now, if you go and talk to a teacher or an education psychologist, you might find that they use the term learning difficulty. And if you scratch under the surface and ask them what they mean by that, then that encompasses what I would call a learning disability, but it also encompasses anything which might impact on learning, from dyslexia, dyscalculia, specific learning difficulties, and so forth. When I use the term learning difficulties, I mean ICD-11 developmental learning disorder. Really important to distinguish between learning difficulties, where the person will continue to learn and will gain function in some domains in the typical range for their age and in the typical range as an adult, as compared to the person with a learning disability, who again will continue to learn and develop new skills, but will always be at a different level to their typically developing peers, not only with all aspects of cognition, but in all aspects of adaptive behaviour, meaning how they're able to function in everyday activities. Timely identification of a learning disability is the thing I highlight in the editorial I was able to write in September 2020 in Developmental Medicine Child Neurology on the subject. Why does timely identification matter? It enables us to put in place those proactive adjustments to services and support, including throughout England access to the general practice learning disability enhanced annual health service checks from 14 years of age. And this includes the annual influenza immunisation and now importantly prioritisation for COVID-19 vaccination, really important. If the learning disability hasn't been given its name, there's a denied opportunity to get access to these enhanced services, preventative services, and a missed opportunity again to improve outcomes. We want outcomes to be better, but we need to get the right steps in place. So when I was reflecting with colleagues across the Cumbria and North East Learning Disability Clinical Network, we talked about wanting to level up the playing field with regard to learning disability. And this included wanting to be able to share resources with families when their child or young person had been identified as having a learning disability. And so Learning Disability Matters for Families was born. This is a resource again that's freely accessible and includes lots of multimedia, examples of positive, reasonable adjustments, lots of signposting to support, information. Also very importantly, Karen Mackenzie's validated screening tool for learning disability, which can be freely accessed by both professionals and families. This isn't a diagnostic tool, but can be used in advocacy to get those extra assessments that might be required, usually from within education, about a child's level of learning ability compared to their typically developing peers and their level of functioning overall. So again, I commend these resources to you. Data. Data really matters. Throughout my career, I have striven, I hope, to meet the needs of the child in front of me, whether it be in clinic, in school, at home, in hospital, in the resuscitation room, to strive to do the very best I can to identify needs and to address them in the most evidence-based way. I believe I also have a responsibility to all the other children and young people in the population with the same level of need as the child in front of me. And I need therefore to think about the care pathways to make sure that there's equality of access to services and thus access to the same and the best outcome opportunities. This is where we need population data, which can evidence variation in access to services and in outcomes. So I will use as an example a piece of work that was based on anecdotal evidence in the north of England of variation in the health outcomes for children and young people with cerebral palsies. And so we framed a research question. Is there variation in healthcare for children with cerebral palsies across Northern England? Back in 2011, there was a big funding call, £30 million of paediatric palliative care. So not all children with cerebral palsies, of course, need palliative care, but I was able to tap into the funding and tweak the wording in such a way that we were awarded sufficient funding to get a really good team together to look at this subject properly. We were lucky also to have good data because at the time the North of England Collaborative Cerebral Palsy Survey still existed. This has since been disbanded by Public Health England, who were no longer keen to support a condition-specific register or database. So from the framework of the population survey, we were able to identify 30 children and young people with cerebral palsy from each of the 15 districts across the north of England, from down as far as North Yorkshire, up to the Scottish borders and across to North Cumbria, so that we could look for evidence of variation. And this work we were able to publish in Developmental Medicine and Child Neurology. Having proper funding, as I said, enabled us to get a proper team together with expertise in epidemiology to really nail the evidence and display it in the clearest way. So one of the aspects that we looked at was access to magnetic resonance imaging, MRI imaging, as a marker of the quality of the diagnostic workup or etiological assessment that the child had undergone. On this graph, each bar in the graph represents a different reporting district. And I think it doesn't require great epidemiological expertise to see that there is indeed marked variation. Variation by geography and probably by managing clinician as well, as to how likely the child was to have been offered an MRI scan as part of their workup. There were a range of other variations that we highlighted in this work. I talked earlier about passive monitoring of the natural history of the condition. So for those with the more severely affected with cerebral palsies, left unattended, their hips will drift out of joint over time and spines may become curved. So we need surveillance in place. This has been evidenced for very many years as being effective. Our colleagues in the Scandinavian countries have got evidence of 20-year follow-up of surveillance programmes, early intervention that can make a difference. In our population, this was in 2011, more than 20% had dislocated hips. Again, there was significant difference between districts in access to orthopaedic surgeons for those most at risk. And there was significant difference also in whether anybody had written down whether there was a spinal curve or not. No record of this at all in just under a quarter of cases. There was significant difference between districts in access to spinal surgeons, and less than half had access to a spinal surgeon in their care team. Pain is known to be a major determinant of the quality of life participation of children and young people with cerebral palsies, as evidenced by big European studies, the Sparkle studies, which people might be familiar with. So we decided to look into the case notes to find out if in the last 2 years' worth of entries in the medical records there was any mention of a discussion with the child, young person or family about the presence or not of pain. Again, it doesn't take great expertise to see that indeed there was very wide variation in practice. It may be pertinent to add at this point that those districts with the least access to MRI were also likely to be the districts with least likely to have documented discussions about pain and to have scored more poorly on the other aspects. Documentation of pain was the one factor in our study that varied by socio-economic status. Thus, those children and young people with cerebral palsies living in the fifth most deprived of the whole population were significantly less likely to have had a discussion about the presence of pain documented. Now, there may have been a range of reasons for that. It may have been that the parent wasn't able to advocate for their own physical or mental health or learning needs. Whatever those factors are, these are environmental, and it's up to us clinicians to be proactive in our inquiries about pain at all times to make sure that it's properly identified and fully addressed. Only then, if we make these needs visible, can we do something about them and improve outcomes. We also found significant variation between the districts in the monitoring of growth and of nutrition. Whilst we were collecting our data, we learned through our collaboration with surveillance of cerebral palsies in Europe of a bigger study across all European countries looking at gastrostomy tube feeding. So because we had some data, we were able to contribute to that study as well and grow the evidence base about variation in access to healthcare and aspects of healthcare for disabled children and young people. So moving forward to 2012, I was in a dark room in a Department of Health building in London with a number of other experts, with parent carers, with paediatricians, with terminologists, with other key stakeholders. And the then National Clinical Director for Children and Young People in NHS England, Dr. Sheila Shribman, laid down a challenge to us. In this 21st century, in the fifth richest country in the world, why do we still not know who or where disabled children are in our communities, or what their multifaceted needs are? So we seized a range of opportunities. We'd already been collecting data in detail about the multifaceted needs of disabled children and young people in our Sunderland disability clinics, going back to June 2007. The Academy of Medical Royal Colleges was running a SNOMED CT project. SNOMED CT is a coding system that allows us to describe very exactly what we mean by what we say and encourage harmonisation of the terminologies that we use. Also being developed around that time was NHS Digital's Children and Young People's Health Services data set, the SIPS, which has since evolved into the Lifespan Community Services data set. So with regard to the multifaceted needs of disabled children in our local population, I'd like to explain how we went on a journey to developing a paediatric disability terminology set. Myself and our team looked at over 8,000 structured electronic clinic letters of nearly 2,000 children and young people seen in our service. This was made easier because all clinicians in the service use a very structured approach to their letters with active concerns, diagnoses listed clearly so that we could find them and record the commonest ones. So we made a list of the 83 commonest ones. We then had a national working group which was multidisciplinary, and most importantly had input from parent carer who was able to keep us relevant on our feet on the ground, so that a list of 83 grew into a list of 122 terms. There were then separate working groups from backgrounds in community paediatrics and general paediatrics which came up with their list of top terms. Then the fun started with a lot of discussion, debate, sometimes heated, about areas of overlap because we needed to agree and reach consensus onto the final terminologies, and our initial set included 296 terms, which we then published as a SNOMED CT reference set. This was underpinned by an explanatory glossary to explain exactly what we mean by each of these 296 terms, and this is available on the website of the British Academy of Childhood Disability free of charge. To try and make harmonisation of terminologies and this whole business about data collection more interesting and accessible, we decided to add for each of the terms and each condition person-centred outcomes and actions that might be considered by the clinical team when they were undertaking education, health and care planning. Because since the Children and Families Act in 2014, professionals have struggled with how to achieve this in a meaningful way. So we're trying to give a carrot to help people learn to collect good data as well. So a number of publications came out of this work: how we empowered clinical data collection at the points of care, how we developed a disability terminology set and complexity scale, and how we showed that this wasn't possible just in Sunderland but in other places as well, and how we validated the complexity scale from wider data. So some of the data presented in these papers includes looking at the number of needs that disabled children and young people who come along to our clinics experience. If you think about a general paediatric clinic, a child might go along with their asthma or their urine infection or their reflux or their constipation. However, children and young people come into the disability clinic very often have very many needs. So you can see from this graph the number of needs across the bottom, and that significant numbers had more than 10 needs in total. We then, with the help of expert in statistics, mapped the number of disability clinic visits to the number of needs per child, and you can see that this is virtually a linear relationship, an R of 0.97. Pearson's test is really significant and a very close association. So this means that the number of needs across all domains, mindful of the model of disability that I outlined in the first place, the number of needs across all of these domains is going to be directly related to the amount of care that children and young people and their families need. So what is this disability complexity scale? This talks about the health conditions that a child or young person might have, and you simply add up the number. This might include their cerebral palsy, their epilepsy, their continence needs, their disordered sleep, the fact that they were premature, whether they've got congenital heart disease or anything else going on. So the number of health conditions. Then the number of family reported issues, which might be issues at school, housing, with equipment, any environmental issues experienced. The number of technology dependencies, gastrostomies, ventilators, tracheostomies, cochlear implants, anything else, oxygen dependency and so forth. And then whether the child or young person requires round-the-clock care or not. So if you represent a child's needs using H for health conditions and a number, F for family reported issues and a number, T for technology dependencies and a number, and then R for round-the-clock care, this will tell you so much more about the breadth and depth of a disabled child and family's needs than just saying their needs are complex. So how do we go about capturing this breadth of needs and coding it at the point of care? Well, we need to start with what matters most to families. So another piece of co-production that I was pleased to be involved with was developing the traffic light tool, the health, functioning and wellbeing summary sheet. So this goes out for each clinic visit. It was on paper at the moment with a lot of virtual clinics going on, it's electronic. Starts off on one side celebrating what is going well. Otherwise the disability clinic can become a long list of everything the child can't do, which is extremely disempowering. There's then a box to encourage the family to problem solve for themselves. What would make life easier or better, or participation more meaningful? There's then a box for questions and concerns that they want addressed in the consultation. Then on the other side, there's a whole list of health conditions, aspects of functioning, and family reported environmental issues, need for support, information and other, that the families complete traffic light style as to whether they have no concerns, some concerns or serious concerns in each of those domains. This tool then comes into the consultation, empowers families to have their voice heard. Young people can contribute wherever they can and are encouraged to do so. And it enables us to cover a lot of ground quickly and to really hone in on what matters most to the family that day. Importantly, the views and priorities of the family also inform the data capture at the end of the consultation. More about families' views about using this tool can be found in the publication in Developmental Medicine and Child Neurology. So when we do our clinic booking out slip, we capture all of these different needs, health conditions, family reported needs, technology dependencies, and whether round-the-clock care is needed or not. That then forms part of the electronic medical record. Data is stored in our Trust Secure data repository in line with information governance and can be retrieved anonymously for local audits and quality improvement continuously. The data can then flow anonymously behind the scenes to NHS Digital's mandated community services dataset. So what are some of the outputs of these data? So this is just looking at a snapshot of 2 years worth of data from the Paediatric Disability Clinic, and I'll be able to tell you exactly how many children and young people we saw with social, emotional and mental health needs, ever so many of those, how many with speech, language and communication needs and autism spectrum conditions, how many with hearing impairments, vision impairments, chromosomal and genetic conditions, physically disabling conditions, epilepsies, learning disabilities, learning difficulties. We can also apply the disability complexity score across the population of children and young people coming to clinic. So we do see a lot of children and young people, thankfully, with less than 4 needs. We see significant numbers in the disability clinic with between 5 and 10 needs, but we can also clearly articulate the number of children and identify who they are with the most complex needs, with technology dependencies and need for round-the-clock care. This information is really important as we plan care for children and young people, identify with those that pay for services, which children are likely to need continuing care funding and complex care packages, both within paediatrics and as they prepare to transition to adult services. So I believe that an outcome of the data we've captured is we have a better understanding of the multifaceted needs of disabled children and their families. Our care pathways have been informed by real data about these needs. We're able to comply with the mandate to flow data to NHS Digital. And the Disability Complexity Scale now underpins NHS England's currency model pilot for services for disabled children. Ultimately, we hope that tariffs for services will reflect the complexity of needs of children and young people, rather than being a bit finger in the air or which way is the wind blowing, which is what it is at the moment. So now let's think for a minute about environmental factors a bit more. So back in 2015, when I was serving with the executive of the British Academy of Childhood Disability, Contact a Family, which is now known as Contact for Families with Disabled Children, were undertaking their Counting the Cost survey, counting the cost for families of disabled children of having a disabled child. They were wanting to get some publicity for the worrying findings. And so the disability editor of the BBC contacted me because she was wanting to triangulate what paediatricians and other clinicians' views were about the impact of austerity on families with disabled children. So I led a quick survey, in fact a couple of surveys, both open for just a week, that went round all members of the British Academy of Childhood Disability, and this was published in a report in 2015. The findings of the survey weren't surprising to many working in the field, but were perhaps surprising to others because they'd not been made visible before. The fact that paediatric services were impacted by raised thresholds to access other statutory services. It's harder to get into mental health services. They've put their walls up higher. It's harder to access some voluntary services and sometimes social care. 92% of colleagues reported that this had got worse over time. 79% of respondents to our survey described cuts in services to disabled children and their families, and similar numbers unable to meet NICE guidelines for timeliness of assessment, for example, for autism. Reports of increased waiting times were described, in some cases longer than 2 years to see a therapist or a paediatrician or get an autism assessment. Staff in services had often been downgraded, and very many more requests were coming in to clinicians for advocacy on the behalf of families, whether it be about housing, benefits or grants for equipment that used to be available through statutory services. We did get some publicity. Again, this was co-production with my good colleague Mary Busk, parent carer, and we got a bit on the BBC News to try and highlight and shine a light on the impact of austerity on families with disabled children. Once more, I found that getting involved in this piece of work led on to another piece of work, this time on behalf of the European Academy of Childhood Disability. Again, looking at the impact of austerity. This was a partnership between the European Academy, the University of Sunderland, and I led a team including, again, importantly, parent-carer representation, but international representation to look at this important question. So we know that the political response in some European countries to the 2008 financial crisis was austerity and cuts in welfare and cuts in public services. So we wanted to determine the impact on families with disabled children across Europe, both the direct experience of families and the indirect impact on families of cuts in services for disabled children. So we undertook questionnaires that were all via links on the internet. Respondents were from a range of backgrounds, and a significant number met the WHO criteria for poverty in middle-income countries, which was actually quite a big surprise. So we were able to break down our findings into those countries reporting austerity, those with no austerity cuts, and I looked at the UK separately. So this was looking at whether worsening quality of services was described compared to 3 years ago by 734 one families from 32 countries across Europe. And what's notable is the findings from the UK were significantly worse, even from other countries reporting austerity, and very significantly worse than countries with no austerity cuts at all. Particularly bad experiences for those in severe poverty with completely dependent disabled children. Access to services compared to 3 years ago was described as more difficult, and here we compared UK families in severe poverty with dependent disabled children compared to those in the rest of Europe. And again, from the size of the blue segments, you can see significant difficulties with aspects to therapists, support in education, social care support, welfare support and benefits. Overall, there were significantly fewer respondents from countries with no austerity who reported access to services being more difficult. So austerity has impacted on families with disabled children across Europe. Families reported their needs to be less well met than professionals thought they were. We were able to compare responses from families and professionals. UK families in severe poverty reported the worst experiences in Europe, particularly those with completely dependent disabled children in severe poverty. So what about the impact of COVID on top of austerity? Well, the Disabled Children's Partnership has recently published their report, The Longest Lockdown. They received responses from 638 families. 3/4 of them reported delays to routine health appointments, with a negative impact described in over half. The range of additional challenges reported by families with disabled children: 70% more anxiety and behaviour, 66% more problems with sleep, 65% more loneliness, 34% signs of depression. 70% couldn't access therapies at all during the lockdown, and 56% of parent carers also had a disability or health condition. So again, significant impact, double whammy, COVID on top of austerity. So I'd like now to reflect on another piece of work which highlights variation in healthcare for disabled children and young people. This arose as a result of work looking at children's deaths, which highlighted that the most significant group of children who died before their time included those with neurological and neurodisabling conditions. Thus, the Each and Every Need report, which was published in 2018, this programme of work was developed. This aimed to look at the healthcare of children and young people with cerebral palsies aged 0 to 25 as exemplars of all chronic neurodisabling conditions. The aims of the work were to look at the healthcare received by the children, young people and their families in terms of its quality, interfaces with other agencies and services, and that important transition, particularly from children's to adult services. We chose the cerebral palsies to study because they are a spectrum of conditions and may be associated with the whole panoply of physical health conditions, areas of functioning and family reported issues that might be seen with any other disabling condition. So there's a big spectrum that we considered. In terms of how did we reach our study population? Well, because of the lack of good population data about who and where disabled children are, we had to use episodes of inpatient care to identify the study population. So we chose a inpatient window in 2015, inpatient for any reason, whether it was to have an ingrown toenail sorted out, tonsils out, or a specific admission to do with a disabling condition. Those with cerebral palsies were identified if they had an ICD-10 code recorded for cerebral palsies, recognising that the coding for all of this was done by coders rather than by clinicians. We used the age band 0 to 25 because we wanted to capture that very important transition period. So nearly 3,500 cases were identified and reported by local reporters in NHS organisations across all 4 nations of the United Kingdom to the National Confidential Inquiry of Patient Outcome and Death, NCPOD, who coordinated the work. It's important to highlight that when clinicians that know a bit about cerebral palsy got delving into the case records, we had to exclude 119 because it was very clearly evident that cerebral palsy wasn't in fact the diagnosis, it was something else, usually a progressive or other condition. For each child or young person identified, we requested detailed questionnaires about the sentinel hospital admission from how we'd identified them, the acute medical records, the lead clinician for the acute admission and the lead clinician for the disability care were asked to complete questionnaires, and we asked for the medical records for disability care as well as for acute medical care. We also requested information from GPs, and by NCPOD standards this was apparently a good return in terms of the information that we were able to get back. So I do commend the report to you, which makes a range of recommendations which resonate with a lot of what I'm saying today, stressing the importance of improving routine clinical data capture and coding, highlighting how accurate diagnosis and management really matters. If you don't know what you're dealing with, you're not going to be able to put in place those proactive measures that prevent complications from arising in the first place, deal with them promptly and improve outcomes. The report highlights the importance of clinical leadership, of multidisciplinary and interagency care all the way along, and proactive care planning. Transition needs to be planned for, and care needs to be age appropriate and tailored to the needs of the individual. There's a number of recommendations around that. Communication, again, highlighted as so important. Communicating with the disabled child, their family, making sure they're included in all decision making about them. Nothing about me without me. How care is organised, lots of recommendations about that, and then of course recommendations on the environment that needs to be accessible and adapted with proactive arrangements in place. The report highlighted the need for precision in diagnosis. The cerebral palsies require very precise diagnosis. They're not a bucket into which you put everything that's physically disabled and you've not done a proper assessment to work it out. Tone variation, is it spasticity? Is it dystonia? You need to know how to assess this to be clear, because the management of both is different, and indeed there's a nice guideline now on spasticity management, but if spasticity hasn't been correctly identified in the first place, then you're not going to get to those better outcomes. Definite room for improvement in description of functioning of children and young people with cerebral palsies. The gross motor function classification system has been around for over 20 years, very well validated, internationally accepted, published, recognised, and yet in the delve into these very large number of case records, we found record of the gross motor function classification system in only 28% of records. There's not an absence of evidence, but an absence of translation of evidence into the real world of clinical practice. Again, our old friend pain, have we asked, is the child or young person in pain? Are we managing it adequately? Lots of recommendations and room for improvement there. Weight. If disabled children aren't weighed, how can we get their doses of medicines right, or the dose of botulinum toxin right? We cannot. The main reasons given for not weighing disabled children were lack of access to appropriate wheelchair scales or hoisting equipment. These are environmental factors that really must be dealt with if we're to improve outcomes. There was a lack of documentation and making visible the wider needs of the child or young person. If we don't know their preferred communication method or their level of learning ability, if we don't know whether they can see and hear, then we're not going to be able to put in place those proactive adjustments to improve their experience overall, no matter what the setting. So I hope in this presentation I've been able to shine a light on some of the imperfections and variations that continue to exist. But I also hope I've given you the keys to build on that we must all advocate at all levels for if we are to improve outcomes. Those positive, inclusive attitudes, policies and practices underpinning all aspects of our society, our communities, our services that really do honour the equal rights of everyone. Our universal services must be inclusive and understand what inclusivity means and be able to make proactive adjustments, have the right equipment, the right access, the right policies and attitudes. Specialist services need to have pathways of care that are genuinely accessible. It's no good if you live in one particular postcode that you get one particular level of service whilst in another something entirely different. And we will only be able to evidence any of the above if we have robust, comprehensive population data about the needs of all children. Thank you again for inviting me to speak, and I hope that this talk has honoured the memory of an exceptional young man, Adam, and his amazing family. Thank you very much for listening.